thanks for the opportunity. Thanks. So I'll be presenting an article. It's quite interesting to me at least, and hope I feel the same interest it comes to you. So this is about HERTHENA Lung 101 trial. It's a phase 2 trial which had 2 arms, and they are focusing mainly in a new molecule called as Patritumab Deruxtecan. This is again an ADC, antibody drug conjugate, and this they have tried to see whether it is acting in patients who already have progressed on at least 2 lines of therapy. One should be TKI and one should be platinum based. So we know that EGFR mutation is one of the common mutations what we find in molecular landscape of lung cancer, and majority of them are exon 19 del and L858R, which is forms the major part of EGFR mutation, almost 85% of the time. And HER3 is one of the commonly occurring marker, which is very in high percentage positive, almost to the tune of 85 to 100%. The presence of HER3 not only confers a poor prognosis in the term of early metastasis, but also in terms of shorter survival. So when they are positive or when they are present, it is one of the poor prognosis marker for the patient. So beyond second and third line treatment, there are actually no major lucrative options what we have, and whatever we use, either in the form of chemotherapy or some other targeted agent, PFS remains roughly around 2 to 3 months, and the OS does not cross beyond 6 months. So definitely this is an area where more research is required, and new molecules are always welcome. So this is a ray of hope where this HER3 DXd, which is an ADC, which comes into the picture. So this comes from the phase 1 trial, which was done before this HERTHENA trial, and the dose which was found to be effective was 5.6 mg per kg, used once in 3 weeks, which showed an ORR of almost 39%, which was quite encouraging, and hence they went ahead with doing this HERTHENA Lung 01, which is a phase 2 trial. And one more thing what they saw, that it's independent of EGFR mechanism, whether it is EGFR dependent or independent, the mechanism of resistance didn't matter, and it actually showed response to both kind of resistance. So it's a phase 2 multi-center open label randomized controlled trial with 2 arms basically. One was the arm which was having a fixed dose, and other was the up titration dose, and 225 patients were evaluable in the fixed dose arm and 50 in the up titration arm. And mind you, the whole population of this patient was recruited within 1 year. So how were they able to do it? Because this was a global trial including 122 centers across North America, Asia, Europe and Australia. So this is the power of combining the various centers all across the globe and get the recruitment faster and get the results faster. So a biopsy was done for all the patients, and IHC by SP438 platform was done. These all patients also had an analysis of ctDNA. The primary objective of this phase 2 trial was the overall response rate, that's the combination of PRs and CRs by the BICR. So this was the consort diagram. Not too surprised, but they screened almost 400 patients, out of which almost 30 to 40% patients were screen failed, and then from the remaining 277 to 70 were evaluable for further study. So coming directly to the result, so the primary endpoint, which was the ORR by BICR, we can see it was crossed the predetermined value of more than 26.9%, and it was found to be 29.8 in all patients, and previous patients who have used previous third generation EGFR, this osimertinib, it was 29.2%. Not only this, but the patient who had CNS metastasis at baseline, they also were having good response at the tune of 28.7%, and those who did not have CNS metastasis, it was 30.9%. So definitely everybody in this group was getting good results. The disease control rate was to the tune of 70 to 77%, again the best without CNS metastasis. The duration of response was little bit more than 6 to 7 months, and PFS again had shown impressive of 5.5 to 6 months, whereas in most of the other molecules when we use at this level, it is just 3 months. Overall survival again was quite impressive, touching almost 12 to 13 months, and this is again very encouraging because in this setting we don't see an overall survival beyond 5 to 6 months. So this is an individual waterfall plot in the upper half of the slide, and the lower half shows the different mechanism of mutation and dependent EGFR dependent independent TKI resistant mechanism and the presence of HER2 expression. So this is how the different things were present in different patients, and we can see most of the patient had, if we go by the CBR, the clinical benefit rate, almost everybody got, except for maybe 10% patient who did not get benefit, 90% patient did get benefit. So this is again a part of the result where this is the graph for the intracranial or the CNS patients who were affected with CNS, and again it showed that almost 1/3 patient had a good ORR, that was 33%, and there were 1/3 of that actually had CR also. So after the results, obviously we want to see whether this is safe or not. And if you can go through the whole chart, there are, except for the hematological toxicity in the form of low platelet or low neutropenia, anemia, leukopenia. So those are the ones which had grade 3 and above, which were 10% and more. But non-hematological toxicity hardly were more than 5% in any of the noted side effects. So except for the myelosuppression, all the things were quite well tolerated, and grade 1, grade 2, the commonest was nausea. So this will be the last slide. So it's a promising drug, especially in such heavily pretreated patients who otherwise have a worse prognosis, and this was actually compared with the REVAIL study, which used the combination of the targeted therapy and TKIs. And it is efficacious across all subgroups. This is very important, and also all kind of resistant patterns. The only criticism whenever we see a phase 2 trial is we want a phase 3 trial for this, and this is already ongoing by the name of HERTHENA Lung 02. What I am worried, or my criticism is, when I see a lot of myelosuppression, I am worried about AML. So let us see whether this is a reality or just a false threat. So thank you for the patient listening, and I'll stop here.